Hello, everyone. I'm Mohammed.
And I'm Ahmed, and today we're going to talk about COPD.
Every single minute, someone in the world dies from COPD. It's the third leading cause of death globally, yet most patients don't even know they have it until more than half their lung function is already gone.
So today we're breaking down everything: what COPD actually is, what destroys the lungs at a cellular level, how to diagnose it, and how we treat it. Let's get into it.
COPD, chronic obstructive pulmonary disease, is a progressive, irreversible airflow limitation caused by a chronic inflammatory response in the airways and lung tissue, usually triggered by noxious particles or gases. The key word there is irreversible, and that's what separates COPD from asthma, where obstruction is largely reversible with bronchodilators. COPD is actually an umbrella term that covers two main conditions: chronic bronchitis and emphysema, and most patients have a mix of both. Chronic bronchitis is defined clinically: a productive cough for at least 3 months per year for 2 or more consecutive years.
Emphysema, on the other hand, is defined structurally as a permanent enlargement and destruction of the air spaces distal to the terminal bronchioles. Now, what causes it? The number one culprit by far is cigarette smoking. Around 85 to 90% of COPD cases are linked to smoking. But smoking isn't the only cause. Other major risk factors include long-term exposure to occupational dusts and chemicals, indoor air pollution from biomass fuels, and outdoor air pollution. And genetically, the most well-known risk factor is alpha-1 antitrypsin deficiency, where the lack of this protective enzyme allows neutrophil elastase to go unchecked and destroy alveolar walls, the classic cause of COPD in non-smokers.
Alright, so what's actually happening inside the lungs? It all starts with chronic inhalation of noxious stimuli. Most commonly cigarette smoke. This activates macrophages and epithelial cells in the airway, which recruit neutrophils and CD8 plus T lymphocytes to the site. These inflammatory cells release proteases, particularly neutrophil elastase and matrix metalloproteinases, which begin breaking down the alveolar walls. Normally, alpha 1 antitrypsin would neutralize these proteases and keep things in balance. But with chronic smoke exposure, this protective mechanism gets overwhelmed, and the balance tips toward destruction. In emphysema, this destruction enlarges and merges the alveolar air spaces, reducing the surface area for gas exchange, destroying the elastic recoil of the lung. Without that recoil, airways collapse on expiration, trapping air inside. In chronic bronchitis, irritants cause hypertrophy and hyperplasia of the bronchial mucinous glands and goblet cells, flooding the airways with excess mucus. At the same time, cilia become damaged and dysfunctional. Both mechanisms ultimately converge on the same problem: air trapping, hyperinflation, and impaired gas exchange.
So what does the patient actually look and feel like? The classic symptom triad is chronic cough, sputum production, and progressive dyspnea, particularly on exertion. Two classic clinical pictures worth knowing. Blue bloaters are typically chronic bronchitis patients, hypoxic, hypercapnic, and often edematous due to poor gas exchange. And pink puffers, typically emphysema patients, thin, pursed lip breathing, using every accessory muscle to push air out, but maintaining relatively normal oxygen levels for longer.
Diagnosis is confirmed with spirometry, measuring how much air a patient can exhale and how quickly. If FEV1 over FVC ratio is less than 0.7, that confirms airflow obstruction, and in the right clinical context, that's COPD. Once diagnosed, severity is staged using the GOLD criteria based on FEV1 as a percentage of the predicted value, from mild to very severe. But the GOLD 2024 guidelines also factor in symptom burden using the CAT score or MMRC dyspnea scale and exacerbation history, because two patients with the same FEV1 can have very different disease impacts.
First and most important, smoking cessation. Nothing else comes close in terms of slowing disease progression. Good. Deep, slow breath and press once. Proper inhaler technique ensures the medication reaches the lungs effectively. Pharmacotherapy centers on bronchodilators, short-acting bronchodilators for quick relief, long-acting for maintenance, and in severe cases, triple therapy. For patients with low oxygen levels, long-term oxygen therapy can improve survival. Pulmonary rehabilitation helps improve breathing, exercise capacity, and overall quality of life.
So, to bring it all together, COPD is a progressive, irreversible, obstructive lung disease caused primarily by smoking, which causes permanent lung damage to the alveoli. This leads to impaired gas exchange and symptoms like a chronic cough and dyspnea.
For diagnosis, we use a spirometry test. Management then focuses on smoking cessation, inhalers, and oxygen therapy. We aim to stop exacerbations because every flare-up accelerates lung decline.
Thanks for watching.
And share this with a classmate who needs it.